really a pleasure to be here today, and the first person I want to thank is Dr. DeZortz, who's a psychiatrist and co-founder of the company, because he's truly a visionary in the idea that psychiatry needs innovation, just like other areas of medicine do. And as you heard, I'm a neurologist. Please don't hold that against me, being a neurologist. But I think, being a neurologist, really my hope and my vision for Genimind is that it's a natural marriage between psychiatry and neurology. That is, that the advances that we are now having in neurosciences, which are showing us the fundamental mechanisms of psychiatric disorders, and the knowledge that these disorders are biologically based, is probably one of the most important and exciting things that we can really witness in the year 2013. It's very important for us to understand that the movement of biomarkers in psychiatry will create a paradigm shift between our addressing psychiatric symptoms purely symptomatically and treating the fundamental mechanisms that are involved in the etiology of psychiatric disorders. And that really is what the promise of biomarkers are in psychiatry. Here's the bad news, folks. I mean, this is something that is very sobering data from the STAR-D trial. If you look at the vast number of patients with treatment resistance in psychiatry, we're talking about not only depression, but really any major psychiatric disorder, whether it's schizophrenia or post-traumatic stress disorder, or even autism for that matter. A vast percentage of patients remain refractory despite optimal therapy. And this is something that we really should be paying close attention to, because it really behooves us to figure out ways to improve this 50% of our patients to achieve better outcomes than we are right now. One of the most important points, I think, if there are any insurance people that are in the audience, that psychological health is as much a physical disorder as any psychological or psychiatric problem is. In fact, if we look at the costs of treating patients with treatment resistance, what we see is that we see with each and every failed medication trial, there's a direct ratio of increased physical costs. Mental health is expensive to the healthcare system. And until we stop treating psychiatric patients in separate silos, as if that they don't have medical problems, or the internist takes care of something over here, psychiatrist takes care of something over here, we're going to continue to experience these incremental costs in healthcare. So what is the change? How many of you just by hands have seen the Thomas Insel debate? It's very funny that DSM-5 is about to be released, and NIH has taken a direct shot at DSM in terms of criticism. People have seen sort of the media attention that this has garnered. The Wall Street Journal did a story on this. What is all the controversy about? Why is NIH actually criticizing the APA's reliance on DSM as a model for psychiatric diagnosis? And the first reason for that is that we're relying as psychiatrists on symptomatic patient reporting. Think about the limitations if you're a geriatric patient with depression, or you're an autistic child, or you're a schizophrenic. How is it possible that you can communicate adequately your internal state to a third party that understands what exactly you're experiencing if already you are disabled by your primary brain disorder? It's a big problem. The second issue that NIH is talking about regarding our reliance purely on symptomatic therapies is that we cannot think of depression as a unitary disorder. Depression is not one condition. Depression is a heterogeneous disorder. Schizophrenia is not a single disorder. It is a heterogeneous disorder. Bipolar is not a single disorder. These are dimensional disorders that don't follow textbooks. So we need to change our paradigm in how we actually approach patients with psychiatric problems that is more etiologically specific. We need to understand what are the biological mechanisms that are involved in the pathogenesis of psychiatric disorders. And that really is what the promise of bringing biomarkers are into clinical practice, is to understand physiology of the brain. It's not to use a diagnostic biomarker to say a patient is bipolar or schizophrenic. It's to understand what are the operative mechanisms that are causing those patients' psychiatric symptoms. This is obviously a very complicated task, right? And it's really where we wed neuroscience with psychiatry. And what we've done is we've actually asked for some help, because to try to figure out the biological basis of Alzheimer's or depression or schizophrenia is a Herculean task. So Dr. Dezortz, in his wisdom, said, bring together the best people, the best minds of neurology and psychiatry to work on a Manhattan project, if you will, to help us figure out the biology of these disorders. And many of you know people on this list: Stephen Stahl, who has been instrumental in educating psychiatry that psychiatric disorders have a neurobiological basis, which we know that they do. Okay, everybody that treats patients, right? How many of you in this room actually treat patients? We know that patients are not simple to treat. Patients are complex. There's compliance issues. There's significant comorbidity between medical and psychiatric disorders. We separate silo those patients. We put the medical disorders over here, the psychiatric disorders someplace else, and somehow we expect in this mix that a patient will have a good outcome. That is not a system that's going to work. We need to integrate our medical and psychiatric care for these patients under one roof to explain that when a patient takes a PPI, for example, like I do, I have heartburn every day, too much information maybe, I'm not sure, but PPIs affect metabolism of SSRIs. So if you have a patient who's buying Prilosec over the counter and you give them citalopram, there's a potential drug-drug interaction which you may never know about because the patient's not going to tell you that they're taking PPIs. So I'm going to explain to you what the significance of that is. But the bottom line is, and let's face it, we right now in the year 2013 are treating patients in a trial and error approach. That's what we do, trial and error. So is there an alternative to treating patients with this kind of approach? And a very important point again, psychiatric disorders are not only painful existentially, okay? They're painful physically, okay? And we also know that if you look at psychiatric patients, they have the highest burden of physical disorders. So patients with diabetes, with hypertension, are at higher risk of developing depression. So we're seeing this amalgam, if you will, between higher chronic physical disease with higher chronic mental disorders. And again, we need to understand how these are interacting to produce both psychiatric disorders as well as physical disorders. Let me give you an example of something in the real world. I'm curious to know how everyone in this room would actually react to this kind of scenario. Typical case, 40-year-old hedge fund manager, must be from New York, right? So, or maybe from the Silicon Valley, I'm not sure. But he presents with depression, irritability, passive suicidal ideation. You do a past psychiatric history. He's had 2 major depressive episodes. One in which he took an SSRI, stopped it because of sexual side effects, and another episode in college in which he didn't treat himself at all. It resolved after 8 or 9 months. Family history is only remarkable for a father with alcohol abuse. Okay? If I ask you which of these medications you would choose next, okay, and just by way of hand, or you could say something other, how many of you would use citalopram as your next line therapy? And you don't have to give me a reason why, just curiosity, just raise your hand, citalopram. Okay, 3 or 4 people. How many would give duloxetine? So another 10. How many would give Wellbutrin? Wow, a lot of Wellbutrin people here. So about 35. How many would use a mood stabilizer in this patient? So another about 5. How many would use a medical food like methylfolate or something like that? Nobody. Well, okay, it's interesting. Oh, 2 people would use medical foods. Okay, but here's the problem. This is a Rorschach test, right? I just asked you to take a look at the picture and what you would do. And everyone in this room is seeing something different. Why are we seeing something different? Because we don't have enough biological data to help us define what our algorithms are in treatment. Okay? So let's back up. What are biomarkers? When we talk about biomarkers, what are biomarkers? When you go to a cardiologist and you have chest pain, what does a cardiologist do? He gives an echocardiogram. He does an EKG. He may do a C-reactive protein and cholesterol levels. Those are biomarkers. Those are biomarkers for the heart. Why don't we have biomarkers in psychiatry like the cardiologists do when you present with chest pain? Why is it that we've not decided that somehow biological evidence is not relevant to our decision-making processes when it clearly is? Okay? So any diagnostic test which gives us information about the brain is a biomarker. And we could talk about biomarkers being something as simple as gene SNPs, all right? And what are SNPs basically? Anyone want to take a gamble at what SNPs are? So think of, no, that's okay. So think of this as in the following way, right? I am a walking textbook of DNA right now, okay? If you were to, evaporate my DNA, I would be evaporated with it, by the way, but all of my biology is written in the textbook of my DNA. If there are typos in this book, and I'm sure there are many typos in my personal encyclopedia, if you will, but those typos may not change the plot of the book, but they're certainly going to change chapters in the story. Okay, those are called single nucleotide polymorphisms. These are letters that are substituted in DNA that change the effects of protein in the body. Okay, and that is one extreme of a biomarker. The other extreme of biomarkers are things like MRI scans or PET scans. That's a biomarker that's actually taking pictures of the brain. Okay, and here's where biomarkers become important. People say, why should I begin using biomarkers in clinical practice? Because many patients have comorbidity. Okay, patients have psychiatric problems with medical conditions, and that leads to polypharmacology. Okay, this polypharmacology, unfortunately, is the norm, not the exception in psychiatric practice. Okay, treatment resistance is the norm, not the exception in psychiatric practice. So our ability to actually help us understand the biology of these disorders, especially in these patients who are complicated or have comorbidity. By the way, if there are any questions during any part of this, please, I don't mind this being more of an interactive as opposed to just giving an hour-long conversation, but I know it's the middle of the day and people sometimes are not wanting to ask questions, but please feel free. If you raise your hand, we'll try to answer questions. Yes, we have a question already. Yes. Don't worry, I'll repeat the question. Yes. How many SNPs there are? Right. So the question is, how many SNPs are there in the human genome? There are lots of SNPs in the human genome, but only a certain amount of those SNPs are clinically significant. And the way that we know that is something called GWAS, genome-wide association studies. We take thousands of bipolar patients, and we look for variants in those patients which are more expressed than people who don't have bipolar disease. All of the SNPs that I'll talk to you about are GWAS discovered. They have clinical, so you can have a SNP and it may mean nothing clinically, okay? And it just is a different letter. But I'll come back to that in a second. So here is what this looks like. I know that a lot of doctors in psychiatric offices don't have phlebotomy. It's very simple. It's a tube that collects DNA through a saliva sample. I'll go over the report with you, and I'll show you how we do consultations to help bridge the gap between information which you may not understand right now and helping to explain what the meaning of those particular results may be. Okay? And here's a broad snap overshot about what you get with the Genemind biomarker panel. Okay? There are two broad-based categories of genes that are in this panel. The first category relates to pharmacokinetic genes, and I'll explain what pharmacokinetic genes are because those relate specifically to drug metabolism. When you take a psychiatric drug, that drug is metabolized by hepatic enzymes, and those enzymes affect the rate and levels of that drug. And that to me is not very sexy or interesting. It's a very linear relationship between a pharmacokinetic gene and a drug level. What's really interesting for those of you that like neuroscience really are the pharmacodynamic genes. These are genes that relate to receptors in the brain, they relate to ion channels in the brain, they relate to glutamate neurotransmission, they relate to methylation in the brain. And I want to do a deeper dive into that because that's really how we're different than other companies. So first of all, you take caffeine, or you drink a shot of alcohol, or you take 0.5 of risperidone. Whatever you take in your body mostly goes through the hepatic enzymes, okay? And every single drug, or most of the drugs in psychiatry, are dependent upon the cytochrome P450 enzymes for metabolism. Why is this significant? And I'll show you the clinical relevance of variations of P450 enzymes, but they affect the blood levels of medications that you're giving. okay? And if you don't know what the P450 enzymatic activity is of your patient's genome, you are potentially giving a higher dose of that medication than you would in a patient who doesn't have that poor metabolism, okay? And then the second thing is what happens here in the site of the brain. How do things like transport proteins of serotonin or glutamate receptors or ion channels actually affect drug response? So what we offer is basically 4 value propositions for biomarkers. One, the most important thing is side effect risk reduction, okay? We want to avoid lethal side effects. It's not good if we give a patient a medication and we develop diabetes or hypertension or cardiac arrhythmia by treating a patient with a psychiatric medication. By the way, folks, we know that's true. We know that a lot of the atypical antipsychotic drugs are producing significant adverse effects. We are saving the brain, but we're killing the body in the process. Okay, so understanding side effect risk is very important to how you prescribe medications. The second important category here is really efficacy. We want patients to get better. How do we make patients get better? The third category, how many of you in this room are having patients ask you about complementary or integrative therapies? Just, wow, a lot of people are being asked that question, right? So the reality is that there are some evidence-based interventions that are non-pharmacological. And how do we know how to choose those interventions without biomarkers? I just had a meeting with Bob Post, who's the former head of NIMH, and we were talking about post-traumatic stress disorder. And he said to the guy from Walter Reed, are you using N-acetylcysteine for your patients with PTSD? This is the former head of NIMH, Bob Post. And he said, oh yeah, I'm starting to do that. N-acetylcysteine is not a drug. And the reason that you've not heard about it is because no one's marketing it. It costs about $10 to get over the counter. But how do you know which patients should get N-acetylcysteine? And I'm going to talk to you about how biomarkers can help us understand which of those patients respond better to medical foods. Oh, and finally, let me skip over something, because if I don't, my medical mimicry. This is a very important category, because it behooves us, when we see patients with psychiatric disorders, to understand there's a handful of medical conditions which will present with primary psychiatric symptoms. And if we address those patients symptomatically, as opposed to understanding what the underlying medical condition is, we are not doing those patients a favor. Okay, so things like hypothyroidism or sleep apnea present with psychiatric symptoms very often, and we really need to understand how to diagnose those patients better. Okay, so side effect risk. Here's the bad news, folks, that almost every psychiatric drug that's in the pharmacopoeia is metabolized by P450 enzymes. Most of this list is not that relevant, but some drugs are relevant. The drugs that are relevant are drugs which have a narrow therapeutic index. Okay, risperidone has a narrow therapeutic index. If you don't give enough risperidone, it doesn't have the efficacy, but if you give too much risperidone, you're putting your patient at significant adverse drug effects. Atomoxetine, a drug for ADD, okay, has a very narrow therapeutic index. Unless you understand the pharmacokinetics of those drugs and how the gene variance of your patient is hepatically metabolizing those drugs, there is potential Russian roulette in those patients. Let me show you some examples of that. So in the CATIE trials, people looked at risperidone, and they correlated risperidone levels with being a poor metabolizer of 2D6. If you have impaired hepatic metabolism based upon a 2D6 variant, you can have 6 times higher levels of risperidone than a patient that doesn't have that variant. 6 times higher levels. You give 0.5 milligrams of risperidone to a patient who's a poor metabolizer, you've given them 3 milligrams of risperidone, not 0.5. Very problematic in patients with a narrow therapeutic index. Okay? 2C19, how many of us were sort of led to believe that SSRIs were totally benign agents? Truthfully, right? We all believed that all SSRIs were benign agents. Well, the FDA issued a warning that citalopram could prolong the QT interval, okay? Prolonging the QT interval could put a patient at risk for torsades, for a cardiac arrhythmia, okay? Because prolonging the QT interval actually leads to cardiac dysfunction. So citalopram in higher doses will prolong the QT interval. Patients with two C19 variants are at higher risk of experiencing that adverse effect. What about antipsychotic drugs? All antipsychotic drugs bind to the D2 receptor. If I move over there, you can still get me? All right, front there. If I give a drug which binds to the D2 receptor, we know that Anil Malhotra had did meta-analysis in the American Journal of Psychiatry that demonstrated that patients who have deletion alleles have less efficacy and higher adverse effects to antipsychotic drugs. That's a deletion allele, meaning that the drug is adversely binding to the D2 receptor. Okay, how many people in this audience are practicing pain medicine or are giving any analgesic medications for their patients? So only a handful. Every analgesic drug, whether it's tramadol or codeine or methadone, requires 2D6 to become from a prodrug to an active drug. If you have hepatic impairments in these enzymes, you are not able to convert the prodrug to the active moiety. And you may think the patient's seeking drug behavior, right? They're saying, doctor, you gave me, 2 Percocets for pain. It did nothing for me. Oh yeah, you're pain seeking. Maybe the patient's not pain seeking. Maybe they have poor 2D6 metabolism because oxycodone is not a pain medication until it's converted to the 2D6 pathway. How many people in the room experience weight gain or obesity in your practices? So almost everyone in this room actually raises their hand. Patients are worried about this. They don't want to gain weight. They want to get better psychiatrically, but obesity or metabolic syndrome are big problems for patients. What is the etiology of how these medications produce metabolic syndrome or obesity? Most antipsychotic drugs block what's called the 5-HT2C receptor. When you have a delicious meal, was lunch pretty good today? Was okay? So when you feel full, it's because peptides released in your gut go to the hypothalamus and actually now tell your brain that you've eaten enough food. When you give an antipsychotic drug, what you're doing is you're blocking the 5-HT2C receptor. You are blocking satiety mechanisms. Patients who have gene variants in that hypothalamic serotonin receptor are more likely to gain weight or develop obesity as a result of these particular gene variants. Okay, so it's very, very important to understand how genetics puts certain patients at higher risk for weight gain and obesity. Any questions so far on the pharmacokinetic genes? On either obesity risk with genetics or citalopram or anything else? Let me move on to efficacy and also to quality of life. All right? Broadly speaking, there are 3 major areas of pharmacodynamic genes in the Genocept panel. The first is called the serotonin transporter gene. Okay, that regulates serotonin reuptake. The second is methylation, because methylation controls the rate of metabolism of neurotransmitters. And the third, which is going to win the Nobel Prize, okay, I'll be willing to put anyone to bet here that this research on ion channel variants is the greatest discovery in psychiatry in our lifetime. Okay, and I'll explain why this. It sounds like hyperbole, but this is research that will win the Nobel Prize because it points to a fundamental mechanism in psychiatric disorders. Okay, so remember this basic chemistry from Stephen Stahl and everybody else? Here's a serotonin transporter, right? When you give a patient an SSRI, whether it's Paxil or Prozac or Zoloft or Celexa, what you've done essentially is you've disabled the transporter protein, leading to higher levels of synaptic serotonin. Okay? So this transporter is critical to the site and function of SSRIs. That transport protein is under the control of gene variants. And there are 2 broad-based categories of gene variants. There's what's called the short allele transporters and the long allele transporters. Okay? And this is very important to understand because not only does short transporters alter the physiology of how patients respond to SSRIs, they also can influence the amygdala and also cortisol metabolism in the brain. Okay? So we know the serotonin transporter is involved in serotonin reuptake. Patients with short transporters are at higher risk of developing anxiety and PTSD. They have a lower threshold for amygdalar activation. Okay? We also know that the serotonin transporter is co-linked to cortisol metabolism. These are your patients. Remember back in the 80s, how many of you are old enough to remember the whole hypercortisolemia theory of depression, besides me, right? So that kind of dropped out of favor, but the reality is that the short transporters are the patients who have higher cortisol burden, okay? And pharmacogenomically, the main clinical significance of these variants is that these patients are less likely to respond to SSRIs. How valuable would it be for a primary care doctor, not a psychiatrist, for a primary care doctor to get a genotype on a patient to know beforehand that the efficacy of an SSRI is less likely in those patients and to move to a second-line therapy rather than waiting for that patient to fail the SSRI treatment? Okay, how many of you have heard of the COMT enzyme? Because this was discovered by Daniel Weinberger, also called COMT. COMT is the primary enzyme in the prefrontal cortex that regulates dopamine degradation, okay, and norepinephrine degradation. So COMT variants affect prefrontal dopamine, and not only do they affect prefrontal dopamine, they've been associated with very specific psychological phenotypes. This has been done through functional MRI studies. It's been done, there's a Japanese study done recently, but essentially, here's how this looks, folks. If you are a Val-Val variant of the COMT gene, that means that you have higher degradation of dopamine in the prefrontal cortex. What would you expect clinically to see in patients with a higher prefrontal dopamine degradation? You would see exactly, you'd see some anhedonia, you would see reduced executive brain function, all the things that dopamine mediates in the prefrontal cortex would be disturbed in patients with what's called the Val-Val variant. The other extreme of that gene variant is called the MET-MET variant, okay? And MET-MET variants have very low COMT activity. What happens to patients with low COMT activity? Not necessarily manic, but if you don't raise your hand, I'm going to call on somebody. Amir? No, just kidding. So, go ahead, Peter, you want to? Actually, so pathological gambling has been associated, it's controversial, whether addiction's related to the Val-Val or the MET-MET. Somebody else, yeah. So there's some data that there's a higher addiction potential, but that data has also not been shown. The main strong association of MET-MET variants is with comorbid fibromyalgia. Okay, patients with chronic pain with depression are more likely to have MET-MET variants. Now, why would you think that's true? What happens when you're in pain? You make more catecholamines, right? Pain is a stressful situation, folks. So you have higher dopamine, higher norepinephrine, higher fight-or-flight enzymes. You have lower COMT activity. You are at risk of developing a comorbid fibromyalgia with pain. Now, interestingly about this, there's a medical food called S-adenosylmethionine, or SAMe, which actually may work better. We don't know yet exactly, but may work better in patients with MET-MET variants because SAMe is a COMT agonist. It promotes COMT enzymatic activity. Okay, you've all heard the MTHFR. How many people are not familiar with the MTHFR story? Because I could skip this over. So a few of you. So when you take a dietary amino acid, whether it's tryptophan or tyrosine, those amino acids are the precursors to create serotonin and dopamine. Okay, tyrosine creates norepinephrine and dopamine, and tryptophan is the precursor to making serotonin. The enzymatic processes that are involved in that conversion process require folic acid. If you have a folic acid deficient state, the enzymes that are involved in the manufacture of these catecholamines becomes impaired. And interestingly, there's a higher rate of depression in patients with MTHFR variants, indicating the need for folic acid in certain patients with psychiatric disorders. Very, very important to understand this because this is work from Mauricio Fava where they actually took methylfolate as an augmentation strategy for patients with depression. And what they demonstrated was that if you were a methylfolate enzymatic defect genetically, your response of responding to a medical food was significantly higher than if you had no folic acid variant. Small study, but a prospective analysis about the relationship of a gene variant to an intervention like a medical food. How many of you know about ion channels? Because this, to me, I think, is the most important discovery in psychiatry in our lifetime. I can't reiterate that. I know it's a product theater, and people, I'm trying to, promote something, but this finding is critical because what we now understand is the brain functions like our hearts function. Okay? As ion channels in the heart regulate the rate and rhythm of the heart, why do cardiologists give calcium channel blockers to patients with hypertension? They're treating ion channel disturbances. These ion channels are also dysregulated in psychiatric states. Many patients with bipolar have abnormalities in the calcium channel, leading to a dysrhythmia, if you will, of the brain. Why is this important? Because understanding that a patient has an ion channel variant means we can now selectively treat the etiology of a psychiatric disorder as opposed to symptomatically treating those patients. And I just met Bob Post, as I mentioned earlier. Nimodipine was a calcium channel blocking drug that they use for bipolar patients, extremely effective. Why? It blocks calcium channels. And Roy Perlis, who's on our advisory board, really deserves tremendous credit for this research. Him and Pam Sklar at Sinai have discovered, and finally the New York Times gave a big nod to this, how important these ion channels are. But think of our brains as hearts. Our hearts and brains have these ion channels. Question, yeah? Potentially. So the question is, do variants in ion channels potentially alter response to drugs which would act as calcium channel antagonists or sodium channel antagonists? The answer is yes, and I'll show you some of that data. That's a very good question. Oh, and actually here is actually Roy is actually doing this right now at Mass General. They began using calcium channel blockers for bipolar patients and seeing efficacy using these drugs like you would use for a hypertensive state. Okay, what about integrative therapies? Because again, a lot of patients are asking about this. I know there's a great deal of skepticism about which integrative therapies could work in clinical practice. The reality is that there's a handful of evidence-based medical foods that have been shown to have antidepressant or anti-anxiety effects. Don't be scared of them. They actually are out there, and there's actually fairly good data that they have a beneficial place in psychiatry. The question is, where? Who do we prescribe these for? How do we know who those patients are that would respond to N-acetylcysteine? How do we know who would respond to methylfolic acid? How do we know who would respond to S-adenosylmethionine? Okay? And here's how that looks, all right? So if you're an enzymatic defect in the methylfolate metabolism, those patients would respond better to methylfolate. If you have a gene variant related to COMT activity, potentially using S-adenosylmethionine, the efficacy data, by the way, for this compound is equal to most antidepressants. And the onset of antidepressant activity is higher. The rapidity of antidepressant response is faster with SAMe than it is with certain antidepressants. And also, there are a couple of variants that are not shown here, that there are other medical foods like N-acetylcysteine, which again, people should look at the evidence for this particular intervention in their practices. What about medical mimicry? Okay, so sleep apnea is a condition which I guarantee you're missing diagnosis for in your practice. Sleep apnea is the single most important reversible cause of cognitive dysfunction in the elderly. You should have a knee-jerk response. An elderly patient comes to you complaining of cognitive dysfunction. Before you give them Aricept or before you jump to a dementia diagnosis, rule out sleep apnea, okay? And there are gene variants that predict higher risk for sleep apnea. Yes? Yes. Yep. Right, so the question was, there's a lot of comorbidity between sleep apnea and medical conditions. Would it not be nice to have a gene variant that tells you higher risk for sleep apnea, refer them to a sleep lab in conjunction before you just give Provigil or some other medication, treat the underlying cause of the condition? Okay, let's go back to this case again. 40-year-old hedge fund manager. Some of you said citalopram. Most of you said Wellbutrin. Some said duloxetine. Okay, the clinician they took the Genocept assay test. The patient was a short transporter allele. They had a sodium channel variant, as one of the doctors mentioned, and they were 2C19 poor metabolizer. Okay, this particular situation led the clinician to go back to the patient and say, by the way, did you potentially have any history of bipolar in your family? And he said, well, I'm not sure, but my dad would go into these rage attacks, and come to think of it, maybe he's bipolar. But the gene variant led to a deeper sort of diagnostic history, family history, and also medical history to tease out potential bipolar symptoms, which were missed actually in the initial intake. Okay, in this particular situation, because the patient had a sodium channel variant, they gave the patient lamotrigine, which is a primary sodium channel blocking drug. Okay, and it was actually a very good outcome. By the way, if anyone would like to get real-world experience with this kind of test, Dr. Karen Raya, who won an award from APA, is here today somewhere. Where is Karen? And you could overwhelm her. Don't overwhelm me if you have questions, because she has real-world experience. I'm sitting somewhere in an office, thinking these things up. So she can give you boots-on-the-ground experience about how these kinds of gene variants affect treatment decisions. Okay, very simply, this is the assay, what it looks like. We could send these kits to your practice. And very important is that we are a service-oriented company. We love to serve. And what I mean by that is education is our passion. We understand that this is an evolving field. Okay, the biomarkers that we're testing right now will be different than the biomarkers we're testing 5 years from now. Our goal is to help you understand what are the utility of biomarkers in your practice, whether it's genetic testing, it could be somebody else's test if you want to call us about that, if it's imaging, if it's proteomics, we actually can help provide information about the relevance of those to your practices. Okay? This report is those of you that are bibliophiliacs. If you have insomnia, you could actually read the report, but it's a very extensive report. It includes every single article that validates. Somebody actually came to me and said, there's no data on gene testing in psychiatry. And I said, really? There's about 1,000 articles, and we have all of them in our report. So, and patients really, really love getting this report. Some of the anecdotes that we've heard from some of the institutions have been that the most interesting thing as part of the discharge planning is going over the report with patients. Okay? We have a portal. Those of you that like electronic medical records, you can retrieve your results electronically. Here's some of our data. People ask for data. 75% of 505 encounters with the Genomind assay, doctors elected to make treatment choice decisions as a result of that. Compliance is a critical issue, folks. You can't get patients better unless they comply. Having biomarkers as part of your practice will improve your patient compliance. I will guarantee that. Because just like when you get a high cholesterol level and you take a statin, if a patient sees that their psychiatric condition has a biological component, they're going to actually more likely stay on medication. For the insurance carriers, people are using this test in a higher, earlier entree because they're realizing that it's improving their outcomes earlier on rather than waiting for treatment resistance. We have several studies. By the way, how many of you would like to get involved in research, even in practice? We have an open label study. This is a no-brainer, okay? You and the patient enroll. We follow these patients in a naturalistic setting to basically document the validity and the clinical utility of a diagnostic test in terms of interventions that you make to demonstrate the real-world opportunity of these tests. And this is, everyone can enroll in this open label study literally today at our booth. Okay, this is the brochure for patients. Just in summary, folks, that we believe that diagnostic biomarkers will help reduce side effects for patients. It will improve compliance for your patients. Simple to use. Most insurances actually reimburse it. That's a big shock, but they are actually reimbursing this test. In fact, most insurers are asking us to help them manage their mental health. We love clinical support. This was me about 10 years ago before I started working for Genimind. I was a little bit less gray, and here's the portal. Okay, so here's the question, folks, I leave you with. Do we want to continue things as usual? Do we want a trial and error approach to psychiatry where we just guess what's wrong with the patient? Or do we want to actually be able to use biomarkers to actually identify the underlying biological mechanisms that are involved in the psychiatric condition and to improve outcomes and compliance?